what is more interesting here is to see that this is the ophthalmic artery, and you can see very clearly that this is the carotid siphon. The ophthalmic artery is originating right from the cavernous sinus. So this is the so-called dorsal ophthalmic artery with an intracavernous origin. So this is a very common variation that you see. The moment you see a dorsal ophthalmic artery originating from the cavernous sinus, you will not be able to see the ILT, because ILT has got 3 branches mainly. It has got 5 branches actually, but 3 branches, out of which the main branch is the anterior branch. So the anterior branch is the one which is ultimately giving rise to the dorsal ophthalmic artery. Now at the same time, if you see carefully, you can see that there is a very, very tiny connection here from the ICA to the ophthalmic artery. So this is a patient in which the dorsal ophthalmic artery is the prominent one, but even the main ophthalmic artery, which would have come from the ICA, has been preserved as a memory. So just remember that these things can happen. Just because you see a dorsal system, it does not mean that the ventral system is completely gone. It might be completely gone, or at the same time, you might have a tiny vessel, which is the memory of that particular situation. Okay, fine. Now let us move away from the angiographic territories and look at this patient. This patient was a 60-year-old male. He had been having this pathology, this disease in the eye with proptosis and with thickening around the orbit. You can see there is some swelling here also in the lateral margin of the orbit. And you can see these black blotches in his eye. He had been having this for the last 3 to 5 years, and gradually it was progressing, and occasionally in between it used to rupture, and the entire patient, eye used to become black with a subconjunctival hemorrhage. Then over the next 3 to 4 months, it used to improve. Then again after 6 months, another. And he was saying very clearly that whenever it used to rupture, the proptosis used to come down. The proptosis used to come down for some time, and then again the next cycle starts, and again the next cycle starts. This is how the whole thing was going on. So he came to us. Any guesses from the audience what exactly this is? Any guesses? Neurologists, my neurology colleagues? Anyone? Say something, say anything. No, it was not pulsatile, there was no bruit. Okay, next. No, no orthostatic changes. Circoid aneurysm typically will be seen in the scalp. It will not be seen in the eye. This is in the eye. This is on the globe. Yes, there is. You can see this area here, the infraorbital rim. It is more puffed up when compared to this side, and even the lateral, the temporal area, is again looking more prominent. No, only the bleeding used to relieve it. So he used to have a subconjunctival hemorrhage. It used to come down for some days, some months, and then again it used to go up. So, okay, as neurologists, we are very fond of MRIs. So I also asked for an MRI, and this is the pre-contrast, this is the post-contrast. We are concentrating on the orbit. You can see that the eyeball is definitely shifted outwards, and you can see that there is something in the orbital cavity here. Now, just before we talk about this, we should just at least have a brief idea about the classical anatomy of the orbit. Suffice to say that in the orbit, we just say that there is a conal area or an intraconal area and an extraconal area. The intraconal area is the area which is surrounded by the extraocular muscles, and you have the posterior part of the globe, and then you have the optic nerve. Along with that, you have the nerves to the extraocular muscles, that is the 3rd, 4th, and 6th nerves. So that is the intraconal part, and then you have the extraconal part. In between all these empty spaces, you have a lot of loose areolar tissue, you have a lot of fat, and you have a lot of myxomatous tissue, normally to cushion the eyeball. So this is the normal anatomy that you need to know for this case. When we go ahead, we can find that when we start comparing the non-affected eye to the affected eye, we can see all these contrast enhancing areas. You can see some amount of contrast enhancement, very patchy contrast enhancement. And on the non-enhanced scans, they look different. They look hypo-intense. All these areas look very, very hypo-intense, and but not to the degree of CSF. So definitely some hypo-intense contents and definitely some amount of enhancement on the contrast was seen in this case. Now, as we go higher up, we also start seeing that there is some problem which is happening here outside the orbit. You can see that? This happening outside the orbit. And then as you go still higher, you can see some problem here in the bone as well. Again, the property is that this is expansile. This is expanding the bone. Erosion of the bone is not so much. That means it is a very slowly growing process. It is not aggressive. It does not seem to be malignant. And then you have an extension of this problem even in the temporalis muscle and in the fascia around the scalp. You can see this? That is in the temporalis muscle. Compared to the opposite side, definitely there is something happening here. So now what do you think this is? Again on T1, these are all hypo. So what do you think? What is this? What you are seeing here basically is what you see here, these are all phleboliths. These are basically very, very slow flow vascular malformations. They belong to the category of hemangiomas, but we are not very sure whether the genesis of these is from a vascular structure or from a lymphatic structure. That will be known only when we start treating these structures and when we puncture them and what kind of liquid comes out. If the liquid is blackish, it is more likely to be a hemangioma type of hemolymphatic malformation. If it is yellow or colorless, it is more likely to be a lymphatic type of malformation. Either way, these will be classically angionegative. That means that when you do an injection, super selective also in the ophthalmic artery or in arteries of that territory, you will not see supply. It is just because the supply is so thin and so filamentous that you don't see it on a conventional angiogram. They will be angionegative, and the best way to access them is from outside. So this is what we saw. So this was basically a Veno Lymphatic malformation, and we decided to go ahead and treat this. So any ideas, any suggestions how we can treat this? What would the surgeons do? Puncture and do what? Embolization with what? Particle or glue, okay. Someone said alcohol. Alcohol in the eye, definitely not, because it will produce a very strong inflammatory reaction and you will have a problem, your IOP will go up. Bleomycin, excellent. Vasculotoxic. Then, anything else? Okay, so what we did for this is, first you obviously have to do a proper angiogram. You have to do an angiogram of all the territories on that side, and you have to make sure that there is no major visible supply from the area that you are going to inject your sclerosants into. Do a lateral view, an AP view, look at the whole area carefully, make sure that there is no blush, make sure that there is no color going into the vascular malformation from all sides. And then, under cone beam CT guidance or ultrasound guidance, or whatever you want, you can inject, or first of all, what you have to do is, you have to decide which one you are going to treat. Because these are not single, these are usually multiple. As you saw, already they were there in 2 different territories. They were there in the orbit and they were there in the temporalis. So this is basically a part of a metameric syndrome again. So wherever that metamere goes, you will have these deposits. So you have to be very clear with the patient. You have to discuss with them. You have to tell them that this is not going to be a curative issue. This is going to be a recurrent issue. And you will probably treat only those parts which are causing the cosmetic problem. You cannot eradicate this because this is from the level of embryogenesis that one metamere has been programmed in such a way that it will keep on forming vascular clumps. So in that situation, the patient was very clear that he wanted his proptosis to be treated. He wanted his disfigurement of the eye to be treated. So we decided to use guidance, and we put multiple needles. We put 5 to 6 needles in different compartments of the vascular malformation. You do, first of all, the first thing that you have to do is the moment you puncture it, you have to allow the liquid to come out so that the whole lesion deflates. The ratio of injection versus exit, if you remove 5 cc, you can inject 1 cc. That is what we have known by literature. I don't know why it's not 2 cc, why it's not 2.5 cc, but all the papers, wherever the literature search has shown, they say that remove something and then use 20% of that volume to fill in. One reason for this is if you remove 5 cc and inject 5 cc of a sclerosant, you will still have a pretty puffed up balloon. So the sclerosant will not act properly. So what you are supposed to do is you are supposed to deflate it. So never aspirate. You're not supposed to aspirate in this. You're supposed to be in a compartment where the flow is free. With free flow, let's say, if you can take out 1 ml or 2 ml, then 1/5 of that you can inject. So out of the 1/5, how we do it is, out of the 1/5, half of it is going to be contrast, and the other half of it is reserved for the sclerosing agent that we are going to use. So first of all, what we do is, we put 5 or 6 needles together in all the different compartments of the vascular malformation. We deflate it as much as possible. Once we have deflated it, we do contrast injections to make sure that we are completely inside the malformation, that we are not going outside the malformation into the orbit. Because for this case, we use bleomycin. Bleomycin is vasculotoxic. So wherever it comes into contact with any vascular structure, it will cause fibrosis. How you calculate the dose of bleomycin is the total cumulative dose of bleomycin over a lifetime should not exceed 0.5 milligrams or half an international unit per kg. So let's say you have a patient who's around 75 kg. You have maybe around 30-35 milligrams of bleomycin to play with in his entire lifetime. Otherwise, it causes bone marrow suppression. It becomes toxic. It's a chemotherapeutic agent. So what we do is, we calculate the dose, and per injection, we don't exceed half international unit. So we prepare it in such a way that if, let's say, we have 6 needles in, we will use 3 international units of bleomycin. That's all. So inject it, first of all, inject with contrast, see where exactly you are, let the contrast be there. This contrast will act as a mask for the next injection. And when you are injecting the bleomycin, you let the contrast be there and you demonstrate during injection that as the bleomycin is going in, the contrast is just getting marginated, so that you do not have any leaks. You do not have any leaks from those vascular structures. So like this, you do all the injections. We did around 6-7 injections in this patient. And also remember, before the embolization, you have to tell the patient that the effects will not be seen immediately. The effects will take maybe around 3 to 4 weeks, and the peak effect will be seen at 2 months. The same holds true for vascular malformations, hemangiomas of the upper limb, hemangiomas of the face, anywhere. Wherever you use bleomycin, it's going to take time. So you inject that, and then immediately post-procedure, nothing special needs to be done. Some of these patients can develop a pyrogenic reaction. They can have some fever. They can have some chills. Use paracetamol. If there is a lot of injection going on, use steroids for a period of around 1 week. and then bring the patient back for a control, just a physical inspection after 4 to 6 weeks. And if you have done your job properly, if you have injected in such a way that you are still intralesional and you are still inside the malformation with no extravasation over a period of time, when the patient comes back to you, this is how it works. This was the pre-embolization of this patient, and this is the post-embolization at 1 month. The vascular malformation is almost completely gone. Now, this patient is in our follow-up still. This is an old case, around 8 years old. He has developed more malformations, but the proptosis is not so bad. In fact, the area which was treated, the outside area also looks like it's a bit deflated. So maybe some absorption of the chemotherapeutic agent from that area via the lymphatic pathways going into the surrounding tissues and causing some amount of regression of those areas as well. So this is what I wanted to show you. These lesions, open surgery is messy. In fact, we have a lot of surgeons here. Open surgery is extremely messy, and I do not recommend open surgery because there is no way that you're going to get the whole thing out. You will get as much as you see on the surface, but the most important parts are the deeper ones. So embotherapy, sclerotherapy is a very, very viable alternative, and that should be used in these patients. We do this for the hand, we do this for the face, we do this for the thigh. So all those people who are coming with me to the lab today, we have a lot of cases in the new lab where we can show you all those as well. And I think this is where we stop. And if you have any questions about this particular case or about the entire orbit or the whole session for today morning, I think we can have a discussion.